Okay, so good morning, everyone. So we had a grand round today. We had very special speaker. It's Dr. Fran Leeuw. He is visiting us, and he's from Netherlands. So the main topic for him is going to be about stroke. Dr. Leeuw is vascular neurologist at the Department of Neurology of the Radboud University Medical Center. His main is on cause of cognitive consequences of cerebrovascular disease in the young and the elderly. He is a very accomplished researcher, and he has been the founder and principal investigator on different studies, including the Round TNC, the Future Study, Odyssey study. He has participated in other studies as well as this PASS, Diagram, Mr. Clean, PSI, iPhone, and DOST. So Dr. Leeuw, actually, he make a little bit like a favor to us. He's now by kind of planning. He take like the time to at least be able to consider us. So it's very nice from him that he's able to do this. I want to also like put more collaborations with him. But Dr. Leeuw, and thank you so much for coming to us.
Thanks, Sergio, for inviting. It's not like your favorite holiday destination. Also trying to do some work here in New York and visit an institution among these your institutions. I'm very honored to be here this morning. So yes, I'm from Nijmegen in the Netherlands. Most people from the other parts of the world and immediately ask, is it very, very far from Amsterdam? But yes, it's only about an hour from Amsterdam, but we also be in Germany, because as you may know, they're very small, so we're very located at the east side of Netherlands. But it's the oldest city of the Netherlands, founded already by the Roots more than 2,000 years ago. So that's, you know, I know a little bit of background. Tell you also a little bit of the back of this presentation, which will mainly be on a very practical approach on young stroke patients, and in between the presentation, I will make detours on our recent scientific work on trigger factor and cancer. So first, I would like to define with you what is a young stroke, and main have a discussion with you. What is the cause? How can we identify the cause of a stroke in the young? And then talk about what if we don't know a cause, because that very often happens with stroke in the young, and then talk about secondary prevention.
So we're having issues with my microphone. Double check. Sorry, is it working right now? Do you have echo? It's working? Okay, very good. Sorry about it.
Yeah, we can hear you.
Okay.
Okay, so go to the question, how to operationalize a young stroke. And we were just discussing with Deb the issue of age and young, and there's also always an issue on when is a stroke called when it occurs in a young individuals, but usually, and it's of course arbitrary definition, operationalized as an age between 18 to 50 years of age, although you also currently have studies going on, including patients up to 60 or 65 years of age. For the purpose of this topic, I will mainly focus on individuals with a young ischemic stroke. This happens roughly in 10 out of 100,000 people in the population, with an overrepresentation of female patients over men in a ratio of 2 to 1. And I think you will typically recognize also in your own stroke unit that across the entire age range, about every 10th patient will be a young patient. And it's really a rare disease when you're in your late teens or early 20 years. You see it roughly, I would say, every 1 out of every 100 patients. There's something worrisome going on. Recent studies from Merel Ecker from our group showed that only over the course of 10 to 12 years, there was a steady increase of the incidence of a young stroke of over 50%. So just over 10 to 12 years, there was an increase of 50%. It's not only to be explained by the increase, for example, of MRIs or improved diagnosis. I think there's also something really going on. For example, I think it's also been alluded upon in other studies here from the US. There's also an increase of concurrent vascular risk factors like diabetes or obesity that perhaps increase of incidence in just over the course of 10 years. On the other hand, there's also some good news, some work we did a couple of years ago when we were investigating mortality and cause of mortality in these young individuals, and we showed a very steep decrease of mortality also again over the course of 10 or 12 years, particularly in these individuals with a young ischemic stroke, whereas we did not see a decrease in mortality in patients who suffered a hemorrhagic stroke. So on the one hand, you see an enormous increase of young patients because of the increase in incidence, and you see a decrease in mortality, meaning that we as a neurologist are being confronted with more and more people that suffer from their stroke, survive the stroke at a very young age, and at their 20s, at their 30s, at a crossing in their life, being confronted with a disease which they often do not know the cause, and they often do not know the long-term consequences. I think that's what we're going to talk about this morning. So one of the main issues, of course, also with elderly people who suffer from a stroke, is what is the cause of the stroke, and if you can identify the cause, does it help in treating this cause? So then you're usually referred to your local young stroke guidelines, your local young stroke protocol. I'm sure you have a young stroke protocol here as well, but this is more or less a list of very many rare causes, hundreds of thousands of rare causes that usually do not exceed the level of anecdotal evidence. There usually is not a very strong causal relation between a cause listed on this list and the cause of stroke. So we try to summarize these causes and the structure and the approach to diagnose these patients a couple of years ago in this paper, if you want to read more about it. Also, a disadvantage of looking at these very rare causes in the young is that you may overlook the very common causes that also play a role already in the etiology of stroke in the young. The overwhelming presence of vascular risk factors was surprisingly present also in young individuals, as illustrated here in these graphs, stratified by men and women. So we summarized this stuff a couple of years ago, coming from various studies across the world. And maybe I simply draw your attention to the left panel of this figure, to the young man 18 to 25 years of age who suffered from a stroke. And you can look here at the blue bar. There's only 20%, or put it the other way around, 80% already at their teenage age had one or more vascular risk factors. And if you look at the other part of this bar, you see that at this very same age, 1 out of 4, 25% already suffered from 2 or more classical vascular risk factors, including diabetes, obesity, smoking, hypertension. I was under the impression when I saw these figures for the first time, I think very high prevalence, and also meant to show you that, of course, there is this list of very rare causes, but don't overlook the common and very often occurring causes, even at a very young age. Well, let's move on to a bit more a clinical approach on how to diagnose the cause of stroke, and maybe first to stress to diagnose a stroke at all. We very often receive referrals from neighboring hospitals and people ask us to investigate the cause, or for example, close a PFO in patients who have not even suffered from a stroke. So I think that is one of the first things that you have to be very clear about, that you indeed know that you suffer from a stroke. And then, of course, an MRI can be very helpful to show that indeed there is a stroke, to identify the location. And I think it's always a very useful distinction to make to identify whether it's caused by lacunar stroke, small vessel disease, or whether it's caused by a territorial stroke. So just to illustrate the importance of a MRI. This is a CT. I think you very often make a CT at your emergency department as well, but it doesn't typically explain why your patient doesn't see anything at all anymore, or has problems with seeing, and your doctor doesn't see anything at all either. If you make an MRI on the same instance, you very clearly see this occipital lobe infarction, posterior infarction, which clearly explains the clinical symptom. You know you're talking about a territorial infarction. I'm not saying you should skip the CT, but I think it's very useful to add an MRI to your protocol so you know what you're talking about. I think this is something that I would like to stress is that sometimes, of course, you can also see with the CT markers of small vessel disease, but an MRI scan is very useful in the early distinction on the type of stroke you're looking at. On the one hand, lacunar stroke, and on the other hand, the territorial stroke, infarct due to a occlusion of one of the proximal arteries of the brain. So what to think of in terms of causes when you have a patient with a lacunar stroke? So maybe the first box is easy because it usually occurs, of course, in patients much older than the young stroke patient. But of course, it occurs in patients who are in their 30s or in their 40s. Usually, it's based on the presence of abundant vascular risk factors, as I just displayed in the graph. But if you have a young patient without any vascular risk factors, it may be worthwhile to ask some additional questions to patients. Does he or she suffer from migraine, for example? This can also cause a subcortical small vessel disease stroke. Has the patient suffered from any pregnancy complication? For example, a HELLP syndrome, preeclampsia, as we now know, is really a stress test for the body of a woman. We see very often these women come 5 or 10 years later, typically with a lacunar stroke, with very clear history of preeclampsia or HELLP syndrome or any other pregnancy complications. Of course, always ask for intoxications or illicit drug use. But also, if all of these boxes are negative, you can think of genetic causes. You may consider that these causes are rare, but particularly when you exclude a number of other causes, the yield of investigating for underlying genetic causes may be high, and I think will become higher in the next years and decades, because we are keep on finding new causes of stroke in the small vessel disease field every year and year. So this was an approach, just as an example, also followed by Tom from the group of Leeuw Marcus, who did this approach, and then in a slightly older group, individuals who suffered from a lacunar stroke below 70 years of age, they were able to identify in 1 or 2% of these individuals new genetic causes of small vessel disease that were not known by the time. And remember, this is an age limit of 70 years. If you limit this age limit to 50 years of age, I'm sure you will find many more causes of small vessel disease. So now let's move on to the territorial strokes. And I think it's a useful way to distinguish several large groups of causes of the stroke into, the one hand, arteriopathies, cardioembolic sources, and a prothrombotic situation that may cause these strokes. So let's first discuss your clinical protocol, how you might easily identify these various causes of stroke in your clinical setting. This is something which we very often find with our Dutch colleagues, which is not always present when a patient is being referred to us, to investigate also the intracranial arteries. Obviously, usually the cervical arteries have usually been visualized, but the intracranial arteries are often missing. I'm a very big fan of making an MRI scan because you do not only do luminography, as I always call it. You can see the contrast in the vessel, but you're also able to visualize the pathology within the vessel wall itself. So if you have the opportunity to choose, I would say choose an MRI scan. And I think this should be more or less be part of a standard approach in every young patient. Because you want to rule out that there is a cardioembolic source, cardioembolic explanation for your stroke. Do an EKG and preferably hold it for a week, and always perform an echo, an ultrasound of the heart. And if you're still convinced that there must be a cardioembolic source, but you cannot find one, you can consider implanting a loop recorder. To consider or to evaluate a prothrombotic state, you do not always have to do additional investigation. Of course, you want to do some lab to test for an antiphospholipid syndrome, for example, but you could, of course, simply ask for the use of oral anticontraceptives, pregnancy and pregnancy complications, and whether or not malignancy was present in recent medical history. So now, first, let's move on in an attempt to unravel the cause of an arteriopathy, because of course, it's on the one hand that the arteriopathy may explain your cause, but next you'll be interested in what causes the underlying arteriopathy, of course. So even in these young patients, the majority will already be due to atherosclerosis. I will show a picture of that later on, with typical locations at the aortic arch or carotid bifurcation. It can also be present intracranial. And a minority, still quite a substantial minority, I would say, is due to a non-atherosclerotic arteriopathy. And there are also some typical observations to be made on imaging, like arterial dissections. I will show a couple of pictures later on. Vasoconstriction, for example, in a case with a reversible vasoconstriction syndrome, and a string of beads, for example, in a patient with fibromuscular dysplasia. I will show a picture of that later on, which again, the arterial dissection is by far the most common cause of a non-atherosclerotic arteriopathy, and the others are really rare. So once you've made this distinction, atherosclerosis, non-atherosclerotic, you can embark on the next level of distinction of the arteriopathies. Of course, your clinical examination and taking medical history can be of great help to identify the cause. As already mentioned before, vascular risk factors may already play an important role, and of course are then to be associated with an atherosclerotic arteriopathy. A caveat may be if you encounter a patient with isolated hypertension, you think, well, I'm done. There's a classical conventional risk factor, and this has caused my arteriopathy. But this may also be present in a patient with a fibromuscular dysplasia, so a non-atherosclerotic arteriopathy, which the hypertension is caused by a renal artery stenosis, for example. Ask, particularly when you encounter a patient with a cervical artery dissection for a recent trauma. It can be very, very minor. I've had patients who were painting their ceilings and suffered from a vertebral artery dissection a week or 2 week later. So it can be really very minor. You may not even want to call this a trauma. Ask for the use of vasoactive medication. nose congestions medication, for example, has been found to be associated with a reversible vasoconstriction syndrome. Ask for a recent infection, radiation therapy that may cause small vessel disease years or even decades later, and a family history, for example, Marfan's disease or Leeuw syndrome that may also be associated with intracranial or cervical artery pathology. So I think that's where it all started, with the clinical signs and symptoms. Then we try to get a better understanding of the cause of the underlying arteriopathy. On the one hand, as I just alluded upon, clinical symptoms may help, but also the anatomical location of the arteriopathy may help in identifying what particular disease we're talking about. And I think this is mainly based on findings from child neurology, pediatric neurology. We try to exchange knowledge with pediatric neurology. I think we can learn a lot of them when it comes to their classification of the risk factors and also of the kind of classification of these arteriopathies. You typically can distinguish between a unilateral or a bilateral arteriopathy and between an aortic cervical arteriopathy. And I will show you some imaging examples. So this was a woman we saw a couple of years ago who apparently had a very striking arteriopathy with almost no flow here in the left middle cerebral artery, and it appeared that she suffered from a neuroborreliosis a couple of years earlier. And then afterwards, she suffered from recurrent vascular events, recurrent strokes and TIAs in the left hemisphere. And this is the conventional angiogram we made after, because she went to the workup of an extracranial intracranial bypass. You clearly see here on the right hemisphere almost normal angiogram. Here you see here, particularly in the supply of the medial cerebral artery branches, that there is the problem due to the arteriopathy caused by the neuroborreliosis. And indeed, she underwent this bypass, and years after, she's still doing very well without any recurrent episodes of cerebral ischemia. Another infection-related arteriopathy, so to say, is this, I think, also comes from findings from child neurology, which they found that respiratory tract infections already early in your life predisposes to arteriopathy later in life. And this, I think, could be an example of such an etiology, although it's always very difficult to assess causality, of course. But this was also a woman who came with a stroke to our department with the following MRA, the occlusion of the middle cerebral artery. This can be very nicely seen here in this MRA. And of course, it doesn't prove that her frequent occurring respiratory tract infection in her youth predisposed, in her case, to this arteriopathy. There was no single other clue that led us to another cause of her arteriopathy. And this is also an interesting and more observed arteriopathy now with the increased use of neuroimaging and with the visualization of the cervical arteries, a carotid web, some form of intima hyperplasia, which is usually located at the posterior wall of the carotid artery. I have here enlarged it a little bit. And here you see a transverse section, which you clearly see some kind of a double lumen here, caused by the intima hyperplasia in the right cervical artery. So now let's move on to an example of a bilateral cerebral arteriopathy. This may, for example, be the case in a fibromuscular dysplasia patients. Again, here on the right panel, I've enlarged the image of the left. So you can typically see stenotic areas of the vessel being alternated with aneurysmatic dysplasia of the vessel wall. This bleeding here, as can clearly be seen, this can also be present at the other artery, at the right artery, at the right carotid artery. And this is usually diagnosed, as mentioned earlier, in a patient with an unexplained hypertension. And then you go and look for the cause of hypertension. And you very often find a renal artery stenosis, which is more or less indicative for the disease. We tend to follow up these patients more and more often, also for the development of intracranial aneurysm, and now in current guidelines also the advice to follow these patients and to make MRAs also of the Willis circle every 3, 4, 5 years. So now let's move on to one final example of an aortic cervical arteriopathy, a young woman with a Takahashi vasculitis, or vasculitis of the major branches of the aorta. As you can see here, the common carotid artery or the subclavian artery, full occlusion of these arteries at these particular levels of the main branches of the aorta. That may also occur at organs in the abdomen, as for example here illustrated with a renal artery stenosis. So one of the most, I was already referring to that, one of the most frequently occurring causes of arteriopathy, but by and large also causes of stroke in the young, are caused by cervical artery dissection, often iatrogenic, caused by another health worker. And with the advent of neuroimaging, I think we're starting to learn more and more about the disease, and we're seeing these causes of stroke more and more often with a typical flame-like visualization of the arterial dissection here with the conventional angiogram and here on the CT. And again, the advent of MRI, you can also visualize the underlying pathology of the arterial wall. Here again, the dissection. Here you see with these black blood images, you see blood visualized in the artery wall, and you do a transverse section, you very clearly see the underlying pathology with this moon-like structure in the vessel wall, indicative of a arterial dissection. This is also a disease that has been investigated quite often in terms of treatment. For example, in the CADIS trial, this was a randomized trial with recent carotid and vertebral artery dissections in which platelet inhibition was tested versus oral anticoagulation. It was a relatively short-lasting test in which they were looking for endpoints occurring within 3 months among 250 patients, and there was no difference at all in terms of clinical endpoints between the two treatment interventions. I think common practice, at least in the Netherlands, would be that we prescribe these patients platelet inhibitions. And the Dutch approach, and I don't know how you do it in your center, is that we usually follow these patients after 6 months or after a year, do a repeat MRI and check for the presence of irregularities at the vessel wall on whether to decide to continue or to stop with secondary prevention. As promised, one example of an atherosclerotic arteriopathy. Very clearly see here the calcification in the left carotid artery, indicative that particularly patients also suffer from vascular risk factors of an atherosclerotic origin of a arteriopathy. So now let's move on from arteriopathies to the heart. And this is an ultrasound of the heart, an echo of the heart, showing the facets of contrast from the right to the left atrium because of the presence of a persistent patent ram ovale. You talk you through this. Maybe you do not very often see these pictures, me neither. But then all of it, you see the entrance of contrast here in the right atrium, which obviously has to show to the right ventricle here. But also there's already immediate passage of these bubbles to the left atrium and then also to the left ventricle, but then can enter, of course, the systemic arterial circulation. But as you also know, this is a highly prevalent, well, you may not even call it a disease, this is a highly prevalent. Patent trauma are present in 20 to 30% of all individuals in the world. So a number of people sitting here must have a PAVO. There's nothing wrong with that. In most of the patients, it will never lead to a stroke. So that, I think, is the major challenge for us. How do you identify that indeed this PFO is responsible for the cause of stroke, because we now know that treating PFOs, closing PSO in special subgroups are indeed beneficial and reduce the risk of recurrent stroke, but still the number of numbers that you need to treat to prevent one stroke is relatively high, to 40 or 50 patients you have to treat. And this was also done in very highly selected patients who did not have another cause of the stroke. So what we did, we constructed a stroke team in which the cardiologist and the internal medicines and neurologists took place. And all of the referrals that usually went from cardiologist to cardiologist asking, could you please close this PFO, go now via the neurologist, and we go to a structured, systematic way according to a protocol in operationalization of the cause of stroke and whether this was due to the PFO. And I think it starts again with the first question that we also addressed earlier on: is it really a stroke? And we keep on seeing keep on seeing patients who didn't suffer a stroke at all. And obviously, you do not need to close the PFO, of course. You should carefully evaluate according to a structured protocol and exclude other causes of stroke. So do the works, do your MRI and your MRA, do the Holter, test for thrombotic state, and then discuss these patients in a setting in which not only two cardiologists discuss about the patients, but also in the presence of you as the referring neurologist, and also in the presence of preferably internists. Just an example of a patient we saw a couple of years ago, 53 years of age. In September, he suffered from aphasia and some right-sided numbness around his mouth, with complete recovery of all of these symptoms. He had a medical history, according to the referring neurologist, of a TIA, or a minor stroke, and the MRI showed no abnormalities. So, so to say, he followed the advice of making an MRI, but he did it 6 weeks after the event. So that's not a very useful approach, particularly not when symptoms are transient, because of course you may easily miss diffusion restriction or the presence of an infarction if you do it later, 6 weeks later. They didn't investigate an arteriopathy, particularly not intracranial arteriopathy. They found a PFO, and they found a single positive beta-2 glycoprotein. And then the one cardiologist referred to the other cardiologist and say, well, could you please close this PFO? Well, we discussed this patient and we evaluated this patient, and then it occurred that when you did carefully medical history taking, that this patient did not only suffer once from this symptom, but in total 3 times from exactly the same syndrome. So that makes it, of course, very unlikely that a cardiac embolism is 3 times in a row responsible for exactly the identical, very same symptom. And when we did a CTA of the Burgos-Wheeler circle, we saw indeed intracranial atherosclerosis. We did not close the PFO. And this is also the experience we have. I think now roughly 30 to 40% of all of the referrals from the other cardiologists, we do not decide to close the PFO. So now we have discussed some presumed causes of stroke, the arteriopathies, the open foramen ovale, prothrombotic state. But now let's move on to perhaps an even more challenging and pressing problem in our daily life. What if we do not find a cause? Because almost 30% of all of the patients do not have a cause of their stroke at young age, a so-called cryptogenic stroke. And I will first discuss with you the concept of trigger factors. A trigger factor, I don't know whether you're all familiar with the idea, is that it's something different than a risk factor. A trigger factor is the idea may convert a risk factor into a cause. Take an example, hypertension as a risk factor presumably builds up in years or maybe even decades to the development of atherosclerosis, and then in the end, that is the cause of stroke. But it does not explain why on Tuesday morning, 4 a.m., the stroke or the myocardial infarction occurs. That is where the concept of a trigger factor comes into play. So it is a short lasting exposure to a factor that, for example, may create something sudden, which you can understand that it may cause, for example, a stroke, and a sudden occlusion of a vessel, or a sudden rupture of a vessel. Think of a sudden increase in blood pressure, or think of a sudden transient prothrombotic state. Whereas these risk factors, again, have cumulative, long-lasting effect. So these are some examples of these trigger factors: alcohol consumption. You can go through the list: coffee consumption, vigorous exercise, fever. These are all of these factors that may introduce increase in blood pressure, for example, or some changes in the coagulation system. And then the idea is that these trigger factors are active, so to say, just a very short lasting period. And of course, nobody knows exactly how long these periods are. This is a little bit based on pathophysiological reasoning, but most of these studies keep with these times. So lasting from just minutes to hours to almost like a day when it comes to infectious diseases. And this statistical analysis more or less is based on the fact that you calculate the ratio between the frequency of the exposure to the trigger factor during that hazard time, just before the stroke, relative to the frequency of the usual exposure. And the elegant thing of this approach is that this information comes from one and the same patient. So the patient serves as his or her own control. It gets rid of a lot of confounding. So this approach, what we use to investigate the relation in trigger factors and the risk of young stroke, ultimately with the goal to elucidate a little bit of the cryptogenic part of the young strokes. So we did this in our Odyssey study. It's a nationwide study which is led from our institution among 17 sites in the Netherlands. In the end, we included almost 1,500 patients, all with imaging proof of either an hemorrhagic stroke or an ischemic stroke. And for this particular analysis, we used almost 1,150 patients, because patients with a hemorrhagic stroke relatively died early, and those who died, of course, were not included in the analysis, and not all patients were able to finish the questionnaires within a couple of weeks after their qualifying stroke. Still, almost 1,150 patients, and you see some very interesting results. I think this is the relation between trigger factors and any stroke. So meaning combination of ischemic and hemorrhagic stroke. And you see a clear increased risk, for example, for cola consumption, sexual activity, but most are outspoken for the infection-related disorders like a fever or a flu-like disease. So really high relative risks. So now if we limit down this to a patient with a cryptogenic stroke, we see that this relation persists for some of these trigger factors, which may explain a little bit of the, until that moment, unknown causes of a stroke in the young. For example, vigorous physical exercise, but again, fever or flu-like disease was associated with a strongly increased risk of stroke in patients who did not otherwise have a cause of stroke. So all of the arteriopathies, prothrombotic states, conventional classical vascular risk factors were excluded from the analysis. These patients didn't have any other cause of stroke. I think this is also an appealing concept, that these trigger factors may interact with risk factors. We were just discussing the enigmatic relation between a PFO and a stroke, and that is a highly prevalent disorder, the PFO, and that there should be some alternative mechanism that explains when a PFO becomes vulnerable. So we stratified this analysis for cryptogenic stroke, for other strokes, only in the presence of a PFO. And maybe go to the lower part of this table. We saw a very strong relation that if a patient suffered from a flu-like disease or from a fever just the day before the occurrence of stroke, there was a very high risk that the PFO converted into a vulnerable PFO, so to say, was involved in the occurrence of the stroke. Another a recent topic we are working on trying to elucidate cryptogenic stroke in these young individuals is the relation between stroke and cancer. And this came more or less about one of our previous papers already almost 10 years ago, published in the JAMA, also on mortality on stroke in the young. And well, maybe I can ask you, what do you think, what was the most frequent occurring cause of mortality in these young patients? So on average, not even 40. What would be the most frequent cause of death? Cancer. You would perhaps not have expected that in these individuals, but they died most often of cancer. I think we know that stroke can be a manifestation in cancer patients because of treatment, prothrombotic state. But the opposite relation is less well studied, although there are some indications that stroke can be a cancer in disguise. It can be a cancer that has not been discovered yet, but already leads to, for example, changes in the coagulation system, which causes that stroke. And if that were to be true, you would expect a higher risk of cancer during later life. Therefore, we set out to investigate the annual risk of cancer of first ever stroke in young individuals. Try to get a grip of better understanding the cryptogenic cause of stroke. So we did that in a registry-based study, very huge cohort, which was included between 1998 and 2018, administrative databases. Patients were identified through linkers via 3 registries, but we also had reference data on the occurrence of cancer in the rest of the Dutch population who did not suffer from the stroke. So you can compare the risk of cancer in patients who had a stroke and in patients who did not have a stroke. So as I said, a huge cohort, just over 25,000 young stroke patients, the majority ischemic and about 20% hemorrhagic, rather young, on average 44 years of age, a little bit more females. We could follow the cohort for about 6 years. We identified almost 1,000 patients with cancer, with breast cancer the most frequently occurring cancer, followed by gastrointestinal tract cancer and lower respiratory tract cancer. So this is what we see. So this is the risk of stroke, time after stroke, and obviously for comparison reason, I also plotted here the elderly stroke patient, and the elderly stroke patients have the highest risk of cancer, followed by young stroke patients, but who are at the older end of the spectrum, and the youngest 15 between 39 years of age at the lowest risk of cancer. Then if you stratify by gender, by sex, you see this is again the elderly population. Men have a higher risk than women, but this ratio converts when you look at the younger population. Women have a way higher risk the years after their stroke than men. But this in itself maybe is not very meaningful. I think it becomes more meaningful if you compare these risks with the normal Dutch population who did not suffer from a stroke. If you can calculate the excess risk of the standardized incidence rate. And there you see something surprising, that particularly the young individuals have the years after their index stroke, and it goes up to 5, 6, or 7 years of age, depending on the cancer type, have an enormously higher risk of cancer than the patients who did not suffer from a stroke. And this excess risk can be tenfold for these very young individuals. And this steadily declines for the 39 to 50 years of age, and is lower for the elderly stroke patient. Even for the elderly stroke patient, this risk is increased about 2 years after the stroke. So this indicates that indeed, it seems that there is something going on with early cancer manifestations that are not being discovered by the time of stroke, but that pop up after the qualifying stroke. Maybe something else is already going on in the coagulation system, for example, that predisposes these patients to stroke. This again stratified for men and women. Here you see the opposite. That is because of the high background risk of cancer in young women, predominantly breast cancer. That again, this relation conversed as seen in the previous slide. As you may remember that women had the highest absolute risk, but if you compare that with women without a stroke, then there is limited excess risk because of this high background risk of cancer anyway in the population. And then men compared to the healthy peers have a way higher excess risk compared to men without a stroke. So yes, this seems that indeed there is some indication that cancer, manifestation of cancer, maybe play a role in the etiology of stroke because the occurrence of cancer immediately after stroke is so high, and this risk persists for years after the stroke. So some final words on secondary prevention, when to start or when to stop. It's always a little bit of a difficult question as there is not much evidence around, and maybe we start with a little quiz, which is interesting how you deal with this matter. How do you manage your secondary prevention in a young stroke patient? So let's imagine we have a 35-year-old man or 30-year-old woman. So option A, well, age doesn't matter. A stroke is a stroke. One size fits all. I start everything and I never stop platelet inhibition, statins or whatever. Or do you think, well, let's think of it as in a personalized way. And I look at the number of risk factors and I may consider withdrawal of secondary prevention at some time of a life, particularly when it comes to a cryptogenic stroke. I may consider that. So could I see hands for option 1? Do you think a stroke is a stroke and we start treating anyway and we never stop? Is that your approach? And who would favor option 2? Many people favor option 3. Okay. Well, this is maybe option 3 is right because, of course, you need to know a little bit more about numbers. So what are we actually talking about? Because the secondary prevention, of course, is there to prevent some recurrent vascular events. But we must know a little bit about the risk of these recurrent events, and can we quantify the risk of the recurrence event? Well, there's been some work. We did this a couple of years ago, very long time follow-up cohort study. And if you here, for example, look at the composite events after 20 years, you see that roughly about 1 out of 3 patients who had suffered a stroke suffers another stroke or suffers another vascular event, myocardial infarction or revascularization procedure. So this seems quite a high percentage, of course. Keep in mind, it's over a 20-year period. And it's surprising to see that these figures are more or less in line with other European studies who have done this with a bit of a shorter follow-up, but the risks are more or less the same from the Helsinki study led by Mortality or a collaborative study in Italy from Leeuw. They found more or less the same risk. Of course, it's one thing to look at the cumulative risk of a period of 10 or 20 years, but you may also want to be informed about the annual risk, because I think we can assume that the initial risk will be relatively high immediately after the event, which gradually diminishes the years after an event. And maybe there we have the time that we can consider different treatment strategies. And here again, the numbers are quite similar across the studies. Here again, this in red is from Leeuw. This is our work. You see indeed this initial relatively high risk of a composite event, a combination of vascular events. It gradually goes down after a year or 3 to 5, and then it doesn't change too much anymore. It remains at a level of about 1 to 2%. But keep in mind, these are already relatively old studies. The secondary prevention, particularly lifestyle, had a completely different meaning, and I think it nowadays has. So now we have some quantification. But these were the figures for all stroke patients, not taking into account sex, age, cause of stroke. And I think you can think, and you can argue that these risks will be very much different. So if we have here a woman who suffered a stroke because of a carotid artery dissection, her risk of a recurrent stroke will be very different than a man who is 48. And you'd be surprised how many men of 48 already smoke for 35 years, keep on smoking, keep on drinking, and keep on developing conventional risk factors. I think you would immediately agree with me that these risks are not identical. And this also favors a personalized strategy when it comes to thinking about secondary prevention, I would say. Again, there's some quantification available here as well. So we see that also in the long run, women have slightly lower risk than men, recurrence of stroke, and younger stroke patients have lower risk of recurrence events than older stroke patients. And it also depends very much on the type of stroke. So if you have, let's say, a stroke based on large artery disease, even when you're 40, you will resemble an old stroke, so to say. You have a relatively high risk of developing, again, vascular disease and not only cerebrovascular disease. Whereas you suffer from a cryptogenic stroke, this difference can be up to 5 times. The risk can be 5 times lower than compared to a large artery disease stroke. And this also was also found if you calculate the number of risk factors these patients have. So there's really an important distinctions to make in the stratification, the risk stratification of each patient that may perhaps guide you in thinking on what will be the optimal treatment strategy, what will be the optimal secondary prevention strategy. This is again on the very long run, gives you also an impression of how high indeed these yearly risks may be, because it may seem quite high, 56%, which is indeed relatively high, of course, but this is over the course of 25 years. So the yearly risks are still relatively high. Well, maybe the question again, has this changed your thinking? And I haven't mentioned it yet, but there's more and more evidence that particularly the prescription of platelet inhibition is associated with serious hemorrhagic complications. We've done a study in one of our older cohorts, and we have seen that in the long run, so after 15 to 20 years, the cumulative risk of an ischemic event is almost as high as a hemorrhagic event. And it can be hemorrhagic stroke, it can be gastrointestinal bleeding, but all were hemorrhagic complications that required a hospital visit. So it's really quite serious hemorrhagic complication. So how do we deal with this back home in Nijmegen? So if we couldn't find a clue at all, we have a cryptogenic stroke, we typically would treat them for about 3 to 5 years anyway. And then we invite them back to our outpatient clinic. We go back to the charts of the past, or did we miss something? Are there any recent developments that may provide shed some new lights on the cause of stroke? So we re-evaluate the cause of their initial stroke. We talk about compliance, and of course we discuss in detail whether they suffered some other events for which you perhaps visited other hospitals that we didn't know about. But if it's really a cryptogenic stroke without any recurrent effects years later, we start talking with these patients that they may consider withdrawing, particularly platelet inhibition in the years to come. If to find a balance between preventing the risk of new vascular events, but also balancing this with the risk of new hemorrhagic events. And this is typically something these young patients also do expect from you. They want this interaction, they want to be involved with these decisions, and they usually ask already for these discussions very early on in the disease process. So most people in my experience find it very difficult when they're, let's say, 26. They have to take a pill each morning with the idea that they have to do that 60 years, because that's what you're looking at. They have to take these for decades and decades during the rest of their life. Well, the evidence for that is zero. There's never been a randomized trial, including young stroke patients. So just to summarize, I think we're dealing here with a very important public health problem with a dramatic increase in incidence, sudden stroke with people at the crossroads of their life, lifeline consequences. So for the practical approach, use an MRI to tailor young stroke workup. make an early distinction between small vessel disease and territorial infarction that can work on the further differential diagnosis of arteriopathy, cardioembolic stroke, and a prothrombotic stroke. I've shared with you some recent insight in how underlying causes may be at play in the case of cryptogenic stroke. We discussed about trigger factors. We discussed about cancer in disguise. And finally, we discussed about secondary prevention. Quite a substantial number of patients will suffer from a recurrent event, but the annual risk goes rapidly down. And as mentioned, secondary prevention has never been formally investigated in young. Keep in mind, all of these secondary prevention trials were done in patients 50 years of old suffering from atherosclerosis. It's a completely different disease. So I think it's fair to discuss with your patients and also to hear his or her ideas about the sense or nonsense of the lifelong continuation of secondary prevention. Thank you for your attention.
Thank you, Dr. Leeuw, for the great talk. So we have now time for questions. We're going to start here. The first one, there is one here in front. I want to ask the questions.
So I have two questions. First question is for your, do you have a subgroup analysis based on the age of association with the stroke versus which each individual subgroups? Let's say for your like 10 years old, 30 years old, 30 to 40-year-old. And each group, they have a which type of the kind of stroke, either territorial versus
I think when, yeah, I think we haven't done this formal certification, but my gut feeling would be that the older the people are getting, the proportion of people who suffer from a small vessel disease stroke will decrease. This is, of course, also a very prevalent cause of stroke in the elderly individuals and very much associated with classical conventional risk factors. They will increase during aging. And so this, I think, will also be represented in the frequency of small vessel disease stroke in the young. So the older, the more small vessel disease stroke, I would guess.
Another question is about the association with cancer. So do you think that cancers and stroke is an association, or is cancer with the etiology?
Sorry, is it?
So we talk about cancer.
Yeah.
So my question is, do you think that cancer and the stroke is an association study, or is that actually cancer is the cause of stroke?
Well, this, of course, is an association study, but if we replace the word arterial complication with venous complication in patient with cancer, I think we all would immediately prescribe this patient oral anticoagulants, for example, with a leg thrombosis or a pulmonary embolism. It's a very well-known complication of cancer. This has less been investigated in arterial complications of cancer. So yes, for now, of course, it's an observational study which cannot assess causality, but I think there's more than enough pathophysiological evidence to think that in the end it may be causal. And apart from that, I think it also may have some clues for screening. So if you think that cancer may be a cause, and you have a patient with a cryptogenic territorial stroke, and you cannot find anything, you may in the end, and of course we need to do more work about it, do some screening, for example, with the CT thorax or with the PET-CT, to investigate whether underlying malignancy may be a cause of the stroke. So there may be treatment consequences, but it may also have some diagnostic consequences.
Have you ever just looked at it as a cancer registry and look at the patient's age, young patient, on a cancer registry? What is the percentage of patients in that registry compared to the general population?
Sorry, I missed the first part. The younger patients, you said?
So if you look at a cancer registry, just in general, look at a patient between 18 to 59. What is the percentage of patients who have a stroke in that cancer registry compared to general population? So does that make, so is that increased?
I think that is increased, and I think that's one of the relations we know, that patient with cancer, with known cancer, have this increased risk, sometimes because of treatment effect, radiation effect, shared risk factors. So your lifelong smoking may cause lung cancer, but also atherosclerosis, of course. So I think that this association has been established. Here we're trying to investigate the opposite relation.
Thank you for the lecture. In our institution, each year we have a number of patients, young females specifically, who have a history of migraines. And they present with a typical severe migraine headache and focal neurological plexus.
Yeah.
So at your institution, or how would you recommend approaching these patients in terms of differentiating migraine with focal neurological plexus versus migraine as in part? Again, especially in terms of deciding whether to get PPA.
Sorry, what was your last?
How do you decide whether to get PPA thrombolysis for this?
Yeah.
How do you differentiate, or what kind of approach do you recommend these patients?
Yeah, I think when it comes maybe to the last part of your question, when it comes to TPA, intravenous thrombolysis, I think we do not tend to hesitate. So if we think we have a patient who may suffer from a stroke, of course we do a CT, CTP, and a CTA. But if this is negative and a patient is within 4.5 hours, we would treat this patient. And of course, in the end, it may come out that this patient suffers from migraine, but usually you don't see too many troubles if you treat a patient who doesn't have a stroke. Because the alteplase does not cause a rupture of blood vessels or cause major bleeding. It's a patient who does not have a stroke, so this risk is very low. So we often say that in case of doubt, treat and do not postpone your treatment. But when you are, for example, in an outpatient clinic setting, then of course an MRI scan can be helpful if such a patient is being referred to your TIA outpatient clinic, for example. Then an MRI, I would advise to make this differentiation. And of course, I know that there can also be migrainous stroke. You can also show diffusion restrictions, infarctions on your MRI scan. Yeah, I think the true answer is that we do not exactly know what the underlying pathophysiological mechanism of those types of strokes are. Then in the end, a patient with migraine can also have another cause of stroke that I would at least start treating, I think, with secondary prevention of those patients.
Yes.
In the acute setting, we're usually not in much doubt. Our door to needle time is usually 10 to 12 minutes. So there's not much time for thinking.
The cocaine-associated strokes, there's been a lot of controversy about vasospasm, etc. Do we know any more about that?
Just touch upon the last stroke in the young, the age is just a number. If these people have risk factors, then why go to so great lengths to find out that neurology? If, for example, situation is young patient, a lot of people get 20 years of hypertension, they are years old, in that case, I think we try to work on the probability. That's, I think, not necessarily beneficial if we have this burden on the partner there or the last part mentioned about the mortality pathway. I just want to mention if you can tell us
I lost the.
I call it this Dutch TIA guide.
Yeah. 38 to be precise. Yeah. Yeah.
Something like that here. Personally, some of these patients come in with CAD that Monday is a 75 minutes of master video, then we can ask you if you have a day or a third day or something like that.
Yeah. Or maybe start with your first part of your question. Yeah, I think it's a very valid point, of course. If you have a 45-year-old patient, maybe the man on the picture I just showed you, who has been smoking for 30 years, who has diabetes and has hypertension, I think there's no need to look for another cause unless you don't have a pathological substrate. And with that, I mean, if this patient has these vascular risk factors already for decades, but if you don't find any signs of atherosclerosis, both in cervical arteries or intravenous, then I think you should start thinking again, because then, of course, there may be another cause. And these are also typically the patients in which we also would be very hesitant to stop secondary prevention. Of course, if they have already so many risk factors, they would be at risk for another vascular event anyway. So I think we follow the same reasoning. And I think in terms of your aspirin question and the aspirin discussion, I think the Dutch TIA trial indeed was done on a pharmacological basis, and it was shown that 38 milligram inhibited the cyclooxygenase just as much as 300 or even more milligram. By the time they used something like 1,000 milligram, which gave a lot of stomach problems, of course. And nowadays we do not use aspirin, and at least not aspirin monotherapy anymore. We use clopidogrel. And yes, we see some serious hemorrhagic complications of that. So we have quite a few women in our cohort who underwent a hysterectomy because of bleeding complication, because of the use of clopidogrel. So I consider the very serious side effects. And this is something I think that should be introduced in the discussion with your patients, that if you have a risk of 0.5% per year on a new infarction, new vascular event, and the risk of losing your uterus, so to say, is also 1%. I think this is something to discuss with your patient. I think we haven't done that in the past.
Good, last question here.
Thank you very much. Based on the CADIS trial section, you can now shift. But there was a second randomized trial for the section that showed superiority of anticoagulation over antiplatelet. So, if that influences your practice at all, or still just for antiplatelet for the section?
Yeah, we tend to give antiplatelet therapy for the section. We extend the therapy a little bit longer than they did in the trial. I think it's also based in part of European guidelines that we prescribe antiplatelet therapy for about 6 months, and then usually stop.
So the second trial didn't
No, didn't influence our practice. No.
I think this is for the question from most of the things that we trying just do the rounds, and just want to thank everybody to attend these in-person rounds. For the people, so I think there are going to be more questions. I think they can email to review their questions that they want to ask. Thank you, everyone. There's one more round. It's going to be next week. It's going to be week 12. In Trinidad, it's going to be the new chief. He's going to be leading the very round stuff for the last one next year. So, take it one. Thank you. Yeah, no.
Sorry, last second slide.
That you showed.
This one, or?
And then one back here, right? So I'm wondering sometimes when you see their cat